Hello, I'm Professor Mark Bullimore. I make my home in Boulder, Colorado, and I'm affiliated with the University of Houston College of Optometry. We're going to look at the evidence underlying myopia control treatment, understanding the efficacy of different options, and how best to implement it in your practice. So we have now a range of optical interventions. They're all good at slowing myopia progression and axial elongation, and that includes overnight orthokeratology, myopia control spectacles, and myopia control soft lenses. And there's a range of different flavors in each category. Orthokeratology tends to be the most consistent of the results, although it's more effective in children with higher levels of myopia, because with higher levels of myopia, greater corneal flattening causes more peripheral defocus, so you get a bigger dose. In terms of the spectacle lens category, obviously DIMS, HAL, more recently DOT. There's now the CARE design with cylindrical components. They're all good options. And in terms of soft lenses, the only product approved in the US for myopia control, be it drugs or devices, is the MiSight dual focus lens. People often ask me, which is the most effective option? My answer is always the same, the one that the child will use. You get to have a conversation with the child and the parent and see which option is going to best suit the child's lifestyle and which one they're likely to use. So with the 5-year results for the HAL lens, the first thing that's important is there's really good follow-up of the children. So well over 70% of the children who were originally prescribed the HAL lens were still wearing them after 5 years. And when you look at their progression and their axial elongation over the 5 years, it's actually about the same as was observed in the single vision wearers after 2 years. So the first key point is that the HAL lens basically saves you 3 years of myopia progression. Now, what we were also able to do is extrapolate the control data out to 5 years. We see that the lens slows myopia progression by about 1.8 diopters. It slows axial elongation by around 0.7 millimeters. The final thing is that in the 5-year HAL wearers, fewer than 10% of them developed or progressed to high myopia. If you extrapolate the control group, that number is 40%. You're saving 3 years, you got much less progression, and you got much less or fewer children progressing to high myopia. The challenge with atropine is concentrations of 0.01% and lower have been tried all the way up to 1%. Clearly there's a dose-dependent effect. We're still trying to figure out what is the best balance between efficacy and side effects. When I talk to people, they tend to, in the US certainly, start with an optical solution. I often say that there's two problems with atropine. One is it doesn't correct vision, and the second is it doesn't correct vision. So a child still needs an optical correction in order to see clearly, and you have to remember that the incentive for using a drug is limited with atropine. It doesn't make the eyes feel better, it doesn't make the child see better. So you have to remember that. A lot of my colleagues in North America start with an optical solution, and if they're not getting the results that they want or would expect, then they might pivot to something else or even move to a combination therapy. Let me use the United States We have the MySight lens, which is the only product approved by the FDA, but we have a number of other multifocal type soft lenses that can be used off-label. We have overnight orthokeratology, which is approved by the FDA for the temporary reduction of myopia, but it's not approved for slowing myopia progression, although it clearly does. With atropine, we don't have anything approved, but it's compounded in pharmacies is where doctors have to get their atropine from. My advice is, use first of all evidence-based data. Second, use approved options. It can be a challenge when you're limited by availability or indeed your scope of practice. There's a danger to sort of overcomplicate things. I think if I were presenting things to a patient and a parent, I would say these 3 options or 4 options have similar efficacy. They all have the potential to slow your child's myopia, and ultimately how well you do is dependent on the adherence, how well the child uses them. In a case of a myopia control, I think as we evolve, we may move to that and say, okay, Mrs. Jones, I'd like to see no more than 0.1 millimeter growth after 6 months. So let's head off on this course and let's see how we do. But setting expectations is important, but it's also challenging in this sort of new field. Documents like the consensus are useful. It behooves a clinician to keep up to date and see what the very latest evidence is. Just keeping up to date of what works and what clearly doesn't work. And I think the consensus does a good job of saying, don't touch these things because regardless of what people believe, they're not effective. And these are some effective options. What you might want to do is get them going on their contact lenses or spectacles, whatever, and then add the atropine a few months later. Just master one thing and then move on to the next.